Hi, my name is Kathy. I'm a pediatric respiratory therapist in our PICU. And I'm just going to go over the oscillator a little bit, just kind of a really quick rundown of kind of the concept behind it, the patients we use it on, and then generally the settings, how we decide the settings, and what you're going to look for when you're assessing the patients. So this is the oscillator. Looks like it's from the 1950s. Technology has not changed much since it was developed, but it works really well in patients that are getting into ARDS or acute respiratory distress syndrome, ending up with stiffer lungs. And so we use it on patients that are in a situation where we're using high pressures, high oxygenation to ventilate and oxygenate the patient, and they're still not really ventilating and oxygenating. So it's patients with 100% FiO2 and high PEEPs. And then you're also seeing really, really high pressures for really small tidal volumes. And so essentially their lungs are super stiff. And what we're worried about in general when it comes to ventilating a patient and things that we take into account is the shearing force and the shearing trauma of opening and closing the lungs. That can be very traumatic depending on what's going on with the patient, what the settings are and things like that. And it's this trauma that if the lung is closed, it's taking a lot of pressure to open it, it's opening very wide, and then it's closing again, and that's what's causing the shearing trauma. That's why we have all of the ventilator protective strategies that we use, like the lower tidal volumes, lower pressures, things like that. But there are situations where the patient's lungs are so stiff that there's no way to avoid the high pressures, and we're potentially causing more and more trauma. And it's taking the lungs are in a position where they're not able to handle the physiologic opening and closing of the lungs. They're just too stiff, and they're at a place where we need something else, basically. So we'll put them on the oscillator. So the oscillator is when we care about things like the MAP. So when I've talked about before, which is the mean airway pressure, which I know is the same as mean arterial pressure, but it's airway pressure. That's when that's one of the settings that we use on this. So we need to know what the mean settings are on the conventional ventilator. And so then we take that setting and we do generally about 5 above whatever that setting is, and then that's what we set on the machine. The way the oscillator works is it finds that mean airway pressure. So it finds that middle point where the lungs are inflated, but not overinflated, not underinflated. It's kind of this sweet spot in the middle. And it holds the pressure there. And then there's a piston in here that will then vibrate air in and vibrate air out. And so it's at very, very, very fast rates. And so this gets into the concept of minute ventilation that comes up when you're looking at ventilators, and it's the amount of air exchanged over a minute. And it's a calculation of tidal volume times respiratory rate, and you multiply the two together and you get your minute ventilation. And so you can have higher tidal volumes and lower respiratory rates, or you can go the other way. You can have lower tidal volumes but higher respiratory rates. But if you think about the way the equation works, whether you're at either end of it, you have the same minute ventilation. So this will still follow that same concept. It has really high respiratory rates, like hundreds over a minute, but they're super teeny, teeny, tiny volumes. And so you're still exchanging the same amount of air over a minute, but you're doing it in such a way that you're holding the lungs open. Instead of open, close, you're finding the middle sweet spot. And so, again, what you'll set is the MAP. It's generally more or less, there's some variability to it, but about 5 above whatever the MAP or the mean airway pressure was on your conventional ventilator. That's dialed in. There are basically 3 settings that we have. So we dial in the mean airway pressure, and then we dial in what's called the amplitude. And the amplitude is essentially your delta P. So it's the amount of movement in the piston. It's how far forward and how far back the piston moves. It is essentially your tidal volume or your delta P. This is the number that we decide based on what's called chest wiggle. So this is the sweet spot for your chest wiggle is in babies. You want the wiggle down to the knees. In older kids, you want the wiggle to the thigh. And so that literally looks like your patient is wiggling, and we're looking to see how far that wiggle translates down the body. And that's how we decide our amplitude. But again, it is also your, because it's your delta P, it can be manipulated to the ventilation. So it can control gas exchange, not gas exchange, but CO2, exhaling CO2. Then the other settings that we put on here is frequency. Now the frequency on an oscillator is in hertz. And so 1 hertz is 600 breaths a minute. So again, very high rates, very teeny tidal volumes. And so then we will decide the hertz. And hertz is generally decided by kilograms. So it's kilograms of the patient. And then it does have what's called an inspiratory time. This is a percentage, but this is it almost exclusively stays at 33%, and this is 33% of the time they're inhaling, 66% of the time they're exhaling, basically. So again, it's a typical 1:2 I/E ratio. That's how it's decided. Again, we pick the map based on what the conventional ventilator says. The amplitude, we pick a setting and then decide based on chest wiggle, and hertz is decided based on weight. Now, one of the interesting things about the oscillator is it is different from a conventional ventilator in how we manipulate our gases. So on, you have a patient with a high PCO2, right? So they're underventilated. On a conventional ventilator, that means that you turn up your tidal volume or you turn up your respiratory rate. You increase their ventilation. On an oscillator, you actually do the opposite and you generally drop your hertz. And so the reason for that is that by dropping your hertz, you're allowing more time for exhale, which allows the CO2 to leave the body and the patient's gas to normalize. So it is the opposite of what you would do for high or low CO2 from a conventional ventilator. These are one of the ventilators that we really don't do a lot with once they're on. It has a very stiff circuit to it. Traditionally what we've done is, like, you know, you'll position the patient, you'll make it so that there's like a table in between the patient and the ventilator to hold the weight of it, and that's often still done. Patient is not moved very often, so they're not turned every 2 hours like they are in a conventional ventilator. They're usually turned once a shift, maybe, depending on the patient, and they are more often proned, so on their belly, because they ventilate better. Patients tend to ventilate better when they're on their belly. So sometimes they will spend the entire time on their belly, and all we're doing once a shift is turning their head from side to side so that they are getting some relief as far as the head goes. But they're often on a rojo, so that they're not getting any breakdown because we're not turning them very often. They're also not suctioned very often, and that has to do with the lung recruitment. So again, this is another really good opportunity to look at oscillators and lung recruitment videos on YouTube. They'll actually show how long it can take to recruit a very stiff lung when they're on an oscillator. And so we're trying to minimize the amount of suction, because suction is potentially removing some of that pressure, decreasing the pressure, causing the lungs to potentially collapse. And then the other thing we do is anytime that we have to disconnect the patient from the circuit, we clamp the ET2. Because of the stiffness of the circuit, if we're in a position where if we're finding ourselves where we're due to reposition the patient, turn the head, flip them over, whatever it is, it's not as easy to do that with this. They don't, one, the circuit's a lot shorter, two, it's a lot stiffer. And so what we will do then is you will call your RT and not do this by yourself. And you will, what the RT will do is take a pair of clamps and actually clamp the ET2 before they disconnect. And what that's doing is that's holding the pressure. It's not allowing any of the pressure to exhale through the tube. So then when we are done doing what we need to do as quickly as we can, as quickly and safely as we can, we're able to hook them back up, start the ventilator, and we have minimized the amount of pressure that we've lost in the patient's lungs, which minimizes the amount of time we have to spend re-recruiting lung tissue. So again, things like section we don't recommend, turning is not done very often, and we clamp with disconnecting. So the alarm for this, there's really only one alarm that we monitor when it comes to the oscillator, and it's your mean airway pressure. So it's set 2 above and 2 below whatever the mean airway pressure is, and so if it drops or rises, then this will alarm. It's a pretty annoying alarm, and I can go ahead and start this. So this is what it sounds like. When it alarms, so there is a silence button on the machine. It's a 45-second silence. It doesn't allow me to turn it or to extend it. It will silence for 45 seconds regardless of how many times I push the button. So you can silence, but again, I encourage you to let the RT do anything with this. But as soon as the silence turns off here in a few seconds, then this is going to alarm because it's going to alarm for a low pressure, which is what this light is. Any minute now. The other thing that we always try to watch for is that our piston, so that's what the alarm sounds like. We check this as often as we check our conventional ventilator, so it's checked every 2 hours. One of the things we're checking for is the piston is centered, which is what this is, and that's just for wear and tear on the machine. So the piston needs to move through the center, because if it's moving through the right or through the left, it'll wear out the piston on this machine. This is hooked up to a heater, and it will get water in the circuit, and often when there's water in the circuit, you will see fluctuations in your mean airway pressure. The way that I drain the circuit, if you're ever so inclined, I would have your RT do it, but if you really want to do it, if you get a paper towel, you're going to have to hold it over this cap here and tip the circuit back up to drain the water. Once it gets back to here, it actually spits the water out. It does have a water drain down here that drains water from the piston, and so we'll often keep track of that, but anything that gets in the circuit, if you tip it back, we'll spit it out of this thing. That's normal, that's what it's supposed to do, which is why I grab a paper towel before I drain the water. But again, I also encourage you to just, if you're not comfortable doing it, then call your RT and have your RT do it. I think that's it.
What are some complications that the nurse needs to prepare for when they get a ventilator? I mean an oscillator.
An oscillator. So one of the biggest complications that happens with this is the patient pops a pneumo. And so they will end up with air in the chest, and it needs to be evacuated quickly. All of our oscillators have a pneumo kit that comes on that's with the oscillator. It should be something that's checked as part of your safety, including with the bag. But it comes with a syringe, a needle to dart them, the petroleum gauze, and then a tegaderm to put over it. That being said, if you feel like that's what's going on, then your first call is to your physician, your second call is to your RT. And you need as many hands in the room as you can to assess if that's what's happening. Now, as far as knowing whether or not that's happening, it's the same way you would know any other way. You have changes in your sats, changes in your pressure, usually rapidly, like all of a sudden they're dropping their sats. The hard part with assessing for this is that there's no way to assess breath sounds. When they're on the oscillator, you can listen, but what you hear is the oscillation, what you hear is the machine. And so it's often hard to assess it as a breath sound, but you have the kit here to attempt to dart the chest to rule that out as a problem.
So how does nursing assess? How should a nurse take on the responsibility of assessing and documenting? What are they actually documenting if they can't hear anything?
So, to be honest, it's up to what you are comfortable documenting, that if that record is pulled and you have to know what you were documenting, is what you're comfortable doing. So as far as the way that I document, I will document what the chest wiggle is, and I will even document breath sounds as bilateral oscillation heard. You need to make sure that whatever it is you're documenting in such a way that if you have to pull that record in 5 years, because this gets to court, then you can understand what you were looking at.
if they do have a pneumothorax, there will be some changes. Will that wiggle be decreased, or will it be duller on that side?
I could potentially. I mean, you don't have any lung tissue anymore, so the lung tissue won't be oscillating. Um, Personally, that's a little harder to assess, but you would potentially see uh, asymmetry in your wiggle. So less wiggle on the right versus on the left, that kind of stuff.
Okay.
All right. Well, thank you.